topic is on fatty liver disease. And I intend to cover the following areas: risk factors for fatty liver disease, the appropriate screening test for us to do, how to diagnose and treat, and how to initiate the appropriate referrals, and also review current management strategy. I guess in Singapore, the interest in fatty liver disease sort of came upon, I think, more so among the population after the general elections, when one of our MPs was said that he had fatty liver disease and then had liver cancer and so on. So I think, some of my patients who come and see me actually express this concern after they read the Straits Times article. And I guess, therefore, since there's increased awareness among our population, I think it's quite timely that we look at this matter and being able to so-called address their concerns adequately. So before I move on, some terminology. I think we have to define alcoholic liver disease, non-alcoholic fatty liver disease, and NASH, or non-alcoholic steatohepatitis, because certainly given that some amount of alcohol consumption is actually quite common, so we cannot be labeling all fatty liver disease as being due to alcohol. So if they consume less than 21 units of drinks per week for meals and less than 14, then we should not be labeling the fatty liver disease as being attributed to alcohol. So NAFL, or just pure non-alcoholic fatty liver disease, it means that there's actually a steatosis, fatty liver without hepatocyte injury. When we talk about NASH, right, we are talking about fat in the liver with inflammation, and this actually manifests histologically with ballooning of the hepatocyte, with apoptosis, and with inflammatory cells around the hepatocytes. And this may happen with or without fibrosis. So that just to show on the picture what I mean. This is a fatty liver, and on this side, this is a normal one. So you can see here in a fatty liver, we have all this fat within the hepatocytes. And normally we define fatty liver when the amount of fat in the liver is more than 5%. In terms of, but certainly not everyone, most people won't be going for liver biopsy, so we won't define it that way. But in practical terms, right, we may say someone has fatty liver based on the ultrasound finding. But do know that ultrasound is not so sensitive, and therefore somebody with so-called normal ultrasound may still have fatty liver disease. In fact, to show up on ultrasound, you probably need about 20% fat infiltration in order for it to appear brighter than usual. So anything less than that, 10%, 5 to 10% may well still appear as normal on imaging. And the problem is that fatty liver disease is actually quite common. Worldwide, ranges from 5 to 30%. In Singapore, there was a survey that said that maybe 40% of the population may have it. And even a thin person may get it, although it is associated more with obesity and so on. And of note, although there has been some concern about it being a major cause of liver cirrhosis and cancer, but I think most of the time, if it happens, it takes a long while. But do know that most of the time, patients are actually asymptomatic. So if we were to look at the prevalence of NAFL and NASH itself, I think if we were to correlate with obesity, right, I think you appreciate that most of the time, this happens actually much more so in severely obese population compared to the normal general population. So fatty liver itself may be due to a specific cause like alcohol, or it can be associated with insulin resistance, obesity, hypertriglyceridemia, even specific disease states like hepatitis C. Medications such as imidazole, steroids can also predispose to excessive fat in the liver. So this, I think, is important for us all to understand the natural history. So most of the time, patients have what I call simple steatosis. So just increased fat on ultrasound, and there's actually no further progression most of the time, and survival is similar to the general population. About 20% may actually develop NASH. That's when there's inflammation. And of this, some may go on to fibrosis. It goes through a stage of early fibrosis, advanced fibrosis, or cirrhosis. That's about 5 to 10% of this cohort of patients. And ultimately, if a person gets advanced fibrosis, then they may progress to liver-related death, cancer, and so on. And all this takes time. So we are looking at a time span of maybe about 10, 20, 30 years. So what are the risk factors for fatty liver disease? What is well established is obesity, insulin resistance, or frank diabetes, hyperlipidemia, and metabolic syndrome. In fact, all these are actually quite interlinked. So having one should actually prompt us to look for the other. So, meaning to say, if somebody has diabetes or metabolic syndrome, then we should actually screen for fatty liver disease and so on. How may patients present? I think the vast majority are actually asymptomatic. So we may see some laboratory abnormality during a health screening. Some may present with transaminitis. Some may have enlarged liver. But I think majority would be just transaminitis with ultrasound showing fatty liver. Of course, we may have the associated features like metabolic syndrome, diabetes, obesity, and so on. So in terms of actual lab findings, usually the ALT, EST is not that high. It's only about 2 to 4-fold, and usually ALT should be higher than EST. If EST is higher than ALT, then our concern will be, has the person actually reached an advanced fibrosis stage? And certainly there tends to be hypertriglyceridemia as well. So do we need to screen? I think as a policy, right, we don't really need to go out to the population and screen for fatty liver disease per se, because we will probably cause a lot of unnecessary worry in the population, and also effective treatment is somewhat limited at this point in time, and we're not sure whether or not this intervention may actually translate a better outcome. But certainly in patients at higher risk, or where we have already found them to have fatty liver disease, then we need to have some risk stratification to identify whether they are at risk for progression, and whether or not we need to be more intensive in our approach in terms of testing, in terms of treatment. I'd like to introduce you to this very useful tool called the NAFL Fibrosis Score. So it looks at things that you can actually do in your clinic, and so long as you have all this and access to the internet, you can just go to this website and calculate the score, and that can tell you whether the patient is at risk for advanced fibrosis. Now, so we look at age, BMI, hyperglycemia, platelet count, albumin, EST, ALT. So let me just go to the website. How do I? So just for instance, there was a patient that was, or rather he wasn't referred, but he came to me for a second opinion. Because somebody in another place wanted to do a liver biopsy for him. And understandably, the patient and the mom were quite concerned, doing a liver biopsy in a young patient who became obese the last 2 years, and therefore started having mild transaminitis. So his BMI, I can't remember exactly, but I think it was about 32. And he was non-diabetic. His AST, I think, was about 80. Let me see. I think AST was about 60. And ALT was about 60. Sorry, let me go to next. Okay, so let's say both are 60. And then platelet is normal, so we'll just say 240. And then albumin is also normal, so we'll say 40. So with this, right, which you can do very fast within a few minutes, then you just calculate the score, and it comes out minus 2.5. So anything less than minus 1.45, that means to say it's probably, there's probably no fibrosis. Whereas if it's more than 0.675, then it's a good predictor of significant fibrosis, and therefore this patient probably warrant further workup, warrant further intensive treatment, including some form of intensive weight loss, aggressive weight loss program. So okay, now back to our slide. So I think this is a very useful tool. Please take note of it. So what do we do when we have a patient with so-called fatty liver disease? So I think at the very start, right, we'll probably recognize it because we do an ultrasound and it comes back fatty liver. So that means that probably more than 20% of the liver is fat. But is this just normal steatosis, or is it something more sinister? So I think then we have to look at the risk factor, and I think that scoring, the NAFL score, is very useful to help us stratify whether these are no fibrosis or potentially having advanced fibrosis, because then the treatment is quite different. So if we think that there's no risk of fibrosis, then all this can be managed at the primary care. Then it's a matter of giving them the appropriate advice. Of course, if there is a concern more advanced fibrosis, then probably if you have access to a fibroscan, you can just order a fibroscan and it tell us, and fibroscan is actually transient elastography. It assesses the stiffness of the liver. So if the liver has advanced fibrosis, then it appears more stiff and the score will be higher. But if you don't have access to that, you can refer for us to do this test, and then we'll give you the finding. So, but certainly if the patient has no risk of advanced fibrosis, then you probably can reassure the patient. So in that case, the young boy who came to me for second opinion, I just put him on a weight loss program, and I think he got better. So there was no need for me to actually do the biopsy for him. So when is a liver biopsy necessary? That's only when we are concerned that there could be a risk of advanced fibrosis, because biopsy is a gold standard to prove advanced fibrosis. And although later on, when I share with you the treatment option, you may find that it may be somewhat limited, but there are actually quite promising studies that's ongoing, and this patient can potentially join the studies that actually where the early data suggests that fibrosis can undergo regression. So, so I think referral to us would only be necessary when there's a concern about advanced fibrosis. So this patient will probably need to have more intensive approach in terms of treatment and also surveillance for progression to cirrhosis and cancer. So treatment-wise, I think the cornerstone is actually lifestyle modification, weight reduction, gradual weight reduction, and also maybe diet. Some medications have been explored, such as some of the diabetes medicine like metformin, thiazolidine, diones, but all these are actually, or even vitamin E. In fact, I think vitamin E is probably the more well-established treatment modality, but all these are actually off-label treatment. And vitamin E, although it may sound safe, but it has been associated at a high dose with higher risk of all-cause mortality and even increases the risk of prostate cancer in healthy males. So in fact, vitamin E, if we were to prescribe it, we'll probably give for 1 or 2 years and then we stop. And then we assess the patient's risk profile. Other things like treating hypertriglyceridemia, hyperlipidemia is also very important, because these patients tend to have metabolic syndrome, and therefore what may actually affect their outcome may not necessarily be the fatty liver disease per se, but could be due to cardiovascular diseases. And therefore, one has to actually adopt a very holistic approach in terms of addressing all the different risk factors. So as I said, I think cardiovascular disease is the most common cause of death for NAFL and NASH. So therefore, we actually need to stratify the risk and treat accordingly. So if patient has a significant CAD risk, then we need to give them statins, antiplatelet, and so on. And as I mentioned earlier, currently there's no really FDA-approved drug therapy for NASH. There are many studies that are ongoing trying to address the different stage of the fibrosis development. In fact, right now in Changi and also some of the other restructured hospitals, we're actually doing a multi-center RCT that uses this drug, that trying to establish, it's a phase 3 study, trying to establish whether or not it causes regression of severe fibrosis and also regression of cirrhosis. So take-home message. Firstly, I think liver function tests itself are not very good predictors for NAFL. And if we think that somebody has suspected steatosis, then ultrasound liver is the first imaging test. But it will only be positive if there's at least 20% fat in the liver. And also the risk of NAFL and NASH is directly related to the presence and severity of metabolic syndrome. Most patients actually have benign NAFL, benign steatosis without inflammation, so they actually have an excellent prognosis, and therefore we should reassure them. A small subgroup would have inflammation, and this group of patients would tend to have an increased risk of liver-related and cardiovascular mortality. So ultimately, I think for us, working together is a matter of trying to identify the at-risk population, and for those who are at high risk, which you can use the NAFL score to calculate, then we may need to work together to so-called to modify their risk and reduce their risk of disease progression. Thank you.